Welcome to this video discussion organized by Radcliffe on high-power, short-duration ablation of atrial fibrillation or isolation of pulmonary veins. My name is Josef Kautzner. I am from Prague, and I will be a moderator of this discussion. It is my distinct pleasure to introduce Dr. Roland Tilz of University of Lübeck in Germany, and Roland will introduce the topic of high-power short duration. And this will be followed by discussion between both of us.
Dear ladies and gentlemen, it's a great pleasure to give you a brief overview about very high-power short-duration ablation for pulmonary vein isolation. Thank you, Joseph, for the kind introduction. In the next couple of minutes, I would just like to give you a few technological overview, background information, and then insights into the future. So what is very high power short duration ablation? There is no uniform definition, but generally speaking, most operators speak about very high power short duration ablation if you apply at least 50 watts for a maximum of 10 seconds. The aim is a high precision ablation without collateral damage, and high power means more control. So what we do not want is a big weapon with a lot of collateral damage. It's not a Rambo ablation, it's a very precise ablation. So I would like to start with the biophysics of RF lesion formation. Whenever we apply RF current, we lose a lot of energy into the circulating blood. In the tissue, there is always a zone of resistive heating, and the resistive heating is the controllable heating. It's homogeneous and durable lesion. And there is also a zone of conductive heating, which is a zone which is partly reversible and less controllable. So the aim of every lesion is to deploy a large resistive heating and a very small, uncontrollable, reversible conductive heating. The more power you deliver for a shorter time, the bigger the resistive heating gets, and the smaller the zone of conductive heating gets. So what factors impact lesion size? We have controllable lesions and controllable and known factors such as temperature and the power setting, the duration of the energy application, the electrode tip size, and the irrigation. And we have factors which are not or partly controllable or sometimes even unknown, such as the cooling from the cavitary blood flow, but electrode tissue contact consisting of pressure, orientation, or intermittent versus constant electrode tissue contact. Even at a given power, the lesion might be highly variable depending on the irrigation of the catheter, but the same is true for the irrigation of the blood flow, so the natural cooling. If you deliver, for instance, 30 watts with a catheter of a predefined size with the irrigation of 5 mils or 20 mils, the lesion with the small irrigation volume is going to be much larger. This is important to know because basically if you deliver a current, you want to get a lesion and you cannot get rid of the PVC, for instance, it doesn't make sense to change to a irrigated catheter because the non-irrigated catheter produces the larger lesion. So what is the aim of very high power short duration ablation? We want it to be very powerful, very fast, very safe, and very effective. Whenever you deliver current, as I said, you have a zone of resistive heating, which is very close to the catheter, and you have a zone of convective or conductive heating. And again, the resistive heating produces irreversible injury, whereas the conductive heating produces reversible or partly reversible injury. When you deliver very high power, for a shorter duration, the lesion gets more shallow. That's very important. It's more shallow, but it's going to be wider. you have a much larger zone of resistive heating and a much smaller zone of convective heating. This means you have a more shallow, more wider lesion with a smaller zone of irreversible injury. And that's why, in contrary to what we learned when we were young electrophysiologists, to reduce the power at the left atrial posterior wall, it is better to increase the power at the left atrial posterior wall in order to avoid collateral damage. What catheters do we have? There is on one side the Q-dot catheter from Biosense Webster, where you can deliver 90 watts for 4 seconds. It's a predefined protocol. So you cannot deliver 80 or 100 watts, and for 3 or 6 seconds, it's 90 watts, 4 seconds. And you produce well-defined lesions. On the other side, there is, for instance, the flexibility catheter, where there is this protocol with 70 watts for 7 seconds, but this is a non-contact force-guided catheter. And on the other hand, there is the Tactiflex catheter, which was recently introduced, where you apply 50 watts for 10 seconds. In both settings, with all these 3 catheters, you deliver high power for a short duration. Do we have any data comparing conventional ablation with very high power short duration ablation? This is data from Isabel Deisenhofer's group in Munich, where they could demonstrate that high power short duration ablation results in shorter procedure duration, shorter RF time of 12 versus 36 minutes. There was no difference in complications, and there was a better outcome. Do we have any data with the Q-dot catheter? This is data from our center, which was recently published in December 2023, where we compared standard ablation with 90 watts for seconds, high power short duration ablation. And we could demonstrate that the procedure time is significantly shorter, so less than 1 hour. The total RF time is significantly shorter, and the outcome is similar with both technologies. What other catheters are available? A very special catheter is the Affera mapping and ablation system, because it's not a solid tip catheter, it's a mesh catheter with a 9mm diameter of the tip, a central irrigation with micropores. It allows mapping and ablation, and you have a very large footprint of the catheter as compared to a conventional catheter. And in addition, you can not only deliver RF energy, but also PF energy, pulse field energy. Overall, the procedure time, or the PDI time, was 22 minutes in this cohort of patients. What about other catheters? There is the diamond tip catheter, which allows a pure temperature-controlled RF ablation. It's a non-contact force catheter, which allows to deliver 60 watts with, for 60 degrees, 50 watts with 60 degrees. And it's not a truly high power short duration ablation. The aim is to ablate until the electrograms reduce by more than 75%, and you add another 3 to 5 seconds. So it's a different protocol, but than all the other catheters. The outcome is as good as with the conventional catheter. There is a shorter procedure time, but the procedure time is still more than 100 minutes for this fast catheter. And the total RF time is also shorter, so 19 versus 60 minutes. In conclusions, dear ladies and gentlemen, very high power short duration ablation results in less conductive heating and in more precise and more shallow lesion formation. It's an excellent tool for PVI, but it's still challenging for lines and VT ablation because the ablations are more shallow. There are different catheters and power settings available, and they are not single shot devices. I believe that this is a bridge technology because the main challenger and most likely the future is going to be a new energy. It's going to be pulse field ablation. So in summary, it's not a Rambo tool. It's a weapon for precise lesion formation. It's more a James Bond weapon. Thank you, Joseph. And now I'm open for discussion.
Well, I would like to thank you for a very nice introduction of the topic, introduction of different technologies, and now we can discuss. So my question is whether you believe that we should use for this strategy special technologies like QDOT, because it has 6 thermistors with very high precision reading. It has automatic algorithm how to change even irrigation, or we can use any irrigation tip catheter.
Yeah. So I'm a strong contact force believer. I think contact force information is super important. We know that even the most experienced operators in the world cannot know whether they have 3 grams or 50 grams. So the personal perception is wrong. That's why I use contact force catheter in every left atrial ablation procedure. And that's why I think you can either use, I like either the QDOT catheter or the Tactiflex catheter. I think both are excellent. I'm not the biggest fan of the diamond catheter because you have no contact force information.
Well, this is an interesting question I wanted to ask, because I have experience with diamond temp, and we did several studies. And on the contrary, I believe that this technology is forgiving for lack of contact force, because if you have a poor contact, you immediately see that the temperature rise is not good, and you have very high power coming to the tissue. So within 2 seconds, you can see that you create good lesion or not, and without contact force sensing. So I think this is maybe, if you have this specific technology, you may not need necessarily the contact force. But I agree that everybody has a different experience and likes or prefers a different mapping system, for instance.
I agree. Real-time temperature of the catheter tip allows to tell you whether you have a good contact force or bad contact force. The same is true for the QDOT catheter, where you have like a bullseye, which visualize in real time the surface temperature. You have 6 thermocouples at the surface. And if you have no contact or intermittent contact, you don't need to look at the grams because you see it at the temperature at the surface. However, contact force is very valuable to avoid excessive high contact force, which can be very dangerous in terms of perforation or steam bulb formation, but particularly a perforation. And that's why I think it's still a very important parameter.
I think, in my opinion, the main difference might be that if you have this specific technology like QDOT or diamond with multiple thermistors, you have much less chance that you can achieve really overheating of the tissue and pop formation, which may occur if you ablate in some areas with maybe different flow of the blood with technology which is not equipped with these sensors. Another question might be, I mean, I don't know if you have any experience with lattice tip electrode, which is quite large. As you mentioned, there's large footprint. And this also allows very high power, short duration. Within 3 to 5 seconds, you can create big lesion. And in our experience, you can create, for instance, a linear lesion like isthmus CTI ablation within 15 seconds. So what is your opinion on this?
I had the catheter in my hands, but I didn't had the opportunity yet to use it in humans so far. But I agree, it's a super promising catheter. And I think this flexible tip, due to this mesh structure, allows you to have a very continuous wall contact. And the initial data that I have seen is really excellent. So I think it's a very, very powerful tool, which allows to produce not only a durable PVI, but also very good lesion formation. You did important work with this catheter. And yes, I think that's also an extremely interesting catheter.
I think all major companies producing catheter technology now are working in the same direction to have some large tip technology for not only for high energy, but also for pulse field, obviously, and that will allow us to reproduce MACE procedure actually in the atrium. So if you can create durable linear lesions, I think we may completely change our workflow. We may completely change results of ablation, and also increase maybe safety, because I think safety is another issue. How safe is this strategy of high power short duration in general? Because there are certain studies now. So can you talk about the safety?
Yes. So generally speaking, it's a very safe technology. Now you have more shallow lesions, so the collateral damage of the esophagus, you have less collateral damage unless you don't apply several applications at the same spot immediately, one after the other. So you shouldn't have at the posterior wall, the interlesion distance is important. So we have an interlesion distance of 5 millimeters at the posterior wall and like 3-4 millimeters at the ridge to create more deeper lesions at the ridge and more shallow lesions at the posterior wall. Of course, what you must not do is deliver 3 applications in a row at the posterior wall, because then you know that the lesions get even deeper. Generally speaking, it's a very safe technology.
You mentioned that it would be a challenge to use this strategy for VT ablation, for instance. So what do you think about VT ablation? What could be the changer?
Yeah, we do have some experience, actually. We also published our experience for the PVC ablation. So in the RVOT, it works excellent. In the LV summit, where you often need deep lesions, the lesions are often not deep enough. So that's when you often have to change from the very high power short duration ablation to a conventional approach where you reduce the power. And in terms of substrate modification, I did a few ischemic patients. The main merit of the very high power short duration protocol is that you have shorter application, less volume for the patient. And we know that decompensation, that heart failure is a severe concern in severe patients undergoing substrate modification. So that's the main merit. The demerit is that you have more shallow lesions. And that's why in non-ischemic cardiomyopathy, I think that's not the right catheter. For ischemic, I think you can use it. What about your experience and your impression and your recommendation?
We have experience with diamond in ventricle. And obviously, you apply much longer time compared to ablation in atrium with this technology, but it can create very good lesions. And we saw very exceptionally some whitening of the tissue on intracardiac echo, which means that you have overheating of the tissue, and we almost did not see any pops during ablation. So we are running now a study which finished enrollment now, and it's a TRACK-VT study. So we will see very soon results. And that was a feasibility and safety study, not a randomized trial. But certainly there is a promise of these technologies also in ventricle.
But by the way, I mean, it's important to highlight that what I was mentioning now was concerning 90 watts 4 seconds. So 90 watts 4 seconds make more shallow lesions. I think the 50 watt protocol is perfect for ischemic, but also for non-ischemic cardiomyopathy. No. But 90 watts, I think, is not the right protocol for intramural lesions for non-ischemic cardiomyopathy, but it's feasible for ischemic patients.
I have some experience with this kind of protocol, and it is true that you can, because you spend a very short time in each area, so you can place the lesions very precisely, and it's much faster. So I agree that this is a main advantage of this strategy. Why do you think it took so much time to come out with such a let's say recommendation? Because for many years we used just conventional technology. We used a recommendation like 20-30 seconds on one spot with a relatively low energy. So what was the let's say momentum, why it changed?
Yeah, I think the game changers were number one, contact force, and number two, algorithm like ablation index or lesion size index, LSI. So because the contact force told us a minimum force that we have to apply, and the lesion size index tells us when to stop, or ablation index tells us when to stop. So you limit the amount of energy that you deliver, because excessive high contact force and high power and long duration is dangerous. Then you get a high rate. When we started with these catheters, without ablation index, without LSI, we saw more jarring, we saw more steam pops, because we applied the energy for too long. So the high power is safe if you know when to stop. And that's, I think, why in the early days when you and we were young, and when we had a poor contact force, but we didn't know whether it was good or bad contact force, it was the right way to limit the energy in order to avoid atrial fistula, steam pops, perforation. But now where we know the contact force, now where we know when we have to stop, higher power is safer than lower power.
Well, I think we covered most of the interesting questions about high power, short duration. Just to conclude our video discussion, I believe that you very nicely demonstrated what are current technologies, what are current strategies of this ablation, why we should use this strategy. And this is very important for everybody who does ablations of atrial fibrillation to have some data and maybe change strategy. And this is always very difficult because people don't like changes. And if you really have convincing data, you can change, or you should change a strategy, especially if it could be faster, safer, and more efficacious. But I truly believe now, with several years of experience with pulse field ablation, as you mentioned also during your presentation, that this strategy of high power short duration is a kind of intermediate strategy before we will have several platforms available for pulse field application, because this is even faster, we believe even safer based on data we have today, and probably also much more efficacious. And this is now very nice area for research, and I'm very grateful that I could see this development after so many years of doing electrophysiology and ablations both in ventricle and in atrium. So I think for young electrophysiologists, this is really disruptive technology which will change everything what we did until now. So thank you, Roland, for this for your kind contribution. And I would like to thank to Radcliffe for doing this video and for inviting me to this video session and video discussion. So
thank you.
Bye-bye.